very much. And it's great to be here. And this is, a completely different talk, really. So this is about the bigger picture for people with MS. Mary was just recalling when we first met, which was at an ECTRIMS meeting in Dublin, and she remembered us meeting in a Guinness bar in Dublin.
The good old days.
The sad thing about that time was that we flew to Dublin the day after 9/11, so it was back in 2001. And Mary Robinson, who was the president at that time, very inspirational. I don't know if any of you have ever heard her speak, but Mary Robinson was the keynote speaker at that ECTRIMS meeting. And, she stopped and said to us, because it was the day after it had happened, no one knew what was happening. There was lots of airplanes grounded at Dublin Airport. And she just said to us, you are all a force of good. And, that's what I'd really like to say to all of you today. I've got so much admiration for the work that you as MS specialist nurses and MS researchers do day in, day out with people with MS. And a lot of it is about this bigger picture. So what I'm going to try and go through is a sort of general thing about the key social and economic factors, how it varies across the UK, whether we think this is relevant in MS, and also how we can intervene on this. So just going back to the start of the afternoon, which might seem a long time ago for you now, what did you all agree? Is MS a single disease? Who thought it's a single disease? Okay, so nobody, no. And are all people with MS the same?
No.
Absolutely. And if we think about social and economic factors, what do you think is important in the context of MS? Yeah, so work is a big one, isn't it? Family.
Living well with it.
Yeah.
Optimising quality of life.
Yeah. Okay, good. So, it is relevant in MS, isn't it? So let's look at the factors that, affect socioeconomic, or how socioeconomic status really fits into the health outcomes. So what we're talking about, and I think someone just mentioned this, it's not just about length of life, it's about quality of life, isn't it? And I really liked this diagram because it shows us a lot of the different things which I think we can intervene to help people with. So all of these different factors lead to the health outcomes to have an influence on length of life and quality of life. What's interesting is actually clinical care is about 20% of that contribution. Yeah? Health behaviours, I think we're probably all working on this, aren't we? And then here, you've talked about employment, you've talked about family and social support, income, bottom line, and then the physical environment we're living in, housing, transport, and air quality, obviously, is quite a big thing now. So if we look across the most deprived to least deprived, and look at life expectancy, and then look at disability-free life expectancy. So the light green at the top is life expectancy, and this is disability-free life expectancy. And these are the most deprived people, okay? And these are the least deprived people. So look at the difference in that. Look at the difference in life expectancy and how long you can live. And this isn't about people with MS, this is about all of us. This is about the whole population. And then let's look across the UK. So it's interesting, the project I just mentioned to you, the Crimson Project, we did quite a lot of qualitative work with people on disease-modifying treatments about what they thought about the treatments, and we worked with the UCL group in London. And there seems to be this impression that people with MS is the same across the country. The team from Leeds University presented some of the cases, and they presented a patient who was, he worked nights, shift work, manual worker, and he says, I like injection. I just chuck it in bin at the end of week. And it was obviously a Yorkshire patient, yeah. It wasn't a London patient. But the London neurologists were a little bit taken aback by, goodness, this is, so, but let's look at what happens to life expectancy across the UK. So let's look at the differences up here in the northwest, the northeast, Yorkshire and Humber, where I'm based. This is male life expectancy compared to the southwest, southeast, east of England. So there's a big difference. And if we look at Blackpool's up in the northwest compared to Westminster, look at the average life expectancy difference from Blackpool. Average is 74 to 83 in Westminster. People with MS are part of this population. So let's use that as our basis. But it isn't all fine. It isn't as if everything in London is fine. And I don't know if any of you have seen this tube map before, but it's really interesting. So it's looking at, as you travel east from Westminster, each tube stop represents nearly 1 year of life expectancy lost. So in this hugely wealthy city, the changes are dramatic, going from the male life expectancy over here to over here. So one of the things I think we've all got to do is understand the population that we live in, because actually, even in London, there's a big difference, as those of you who are based here will know. I saw a really sad case of a woman who was at a food bank, and she'd been in an abusive relationship, and she had a couple of small children. And towering over her was the Canary Wharf buildings. And the journalist was obviously trying to get a rise out of her and said to her, she's here just before Christmas at the food bank. What do you think about the people that work in those glossy towers? And she said, well, they probably worked really hard to get to where they are. And I thought, isn't that incredible? I mean, not, greedy people, but just actually an amazing comment. But it did really highlight to me that difference in such a small area of London between the absolute wealth and the people at the food bank. This just shows us a little bit, and it helps us with comorbidities in MS, because these are called heat maps, and the orangey-brown colour shows where diseases are most prevalent. So here in the northwest, this is liver cancer, but look at heart disease. Look, here's South Wales as well, where you can see. But here again in the northwest, COPD. I'll talk a little bit about heart vascular disease and MS in the comorbidities. So one of the things is, do we think that this has changed? Do we think that inequalities are getting better in our society or are getting worse? And this really tells us how much worse things are getting, actually. So this is the difference between 1931 and 1991, and the difference between the mortality rates in the different social classes, so social class 1, social class 5. So things are getting worse. And, I'm not going to be party political, but in terms of politics overall, I think we'd all agree that austerity has not been good for people with MS. And I think this just shows, this is a slide that Kate Pickett, who's a big expert in social and economic factors in disease, in this one article, here's a young girl in Skelmersdale. I'm from Liverpool originally, so Skelmersdale's not far from Liverpool, on this housing estate with everything shut up. At the same next to it is, what age can you retire with your £250,000 portfolio? Right next to each other in the same article. So not talking about the UK, but if you look at America, this is very interesting. So Trump, who has, who wants to, really destroy the Affordable Care Act that President Obama set up. This shows about how people's health is compared to the Trump voter. So I thought this was quite interesting. So this shows up here a swing towards Trump, and the red is Midwest, the orangey yellow is in the south of America, and these are the sort of the northeast and west. So as your health deteriorates, the more likely you swang over to being a Trump voter. Isn't that interesting? Yeah. Okay, so that's the sort of general background. And then just to move on to neurological conditions then. So I've shown you about mortality across the UK, and you'll all be from different centres in the UK and different populations. What's happening to people with MS over England in terms of the mean age of death? And this is Public Health England data they published this in 2018. I think this was quite shocking, isn't it? Mean age of death for MS and inflammatory diseases was 66, with 73% of people dying under the age of 75. And compared that to the other different neurological conditions there, would we have expected that MS and inflammatory would be the lowest of those? So that's real food for thought, I think. And then if we look at what's happening in terms of mortality over the since 2001 to 2014, there's been a significant percentage change in mortality for people with neurological conditions and for MS and inflammatory conditions, although all-cause deaths is actually reducing. So this is a problem in neurological conditions overall, and I think we've got to see what else is going on that's affecting mortality like this, especially now today. We've talked a lot about disease-modifying treatments, but there are other factors at play. So one of the questions at the start was, can we intervene on this? I really like this slide. This is about the cholera epidemic. So my view is that we can intervene. But this is so funny, isn't it? I mean, we prefer to take our chance with cholera and the rest rather than be bullied into health. So nothing a man hates so much as being cleansed against his will or having his floors swept, his walls whitewashed, his pet dung heaps cleared away. So I think, obviously, we've moved on, but I think, you know, we can intervene. There are ways that we can intervene, and we shouldn't feel that we're bullying people into health. So we've talked about some of these different things, but all of this links together. So we mentioned, I'll talk a bit about employment, but education, poor education, we're asking people to make. You were talking, Paul, about these complex decisions we're asking people to make with very different educational attainment. So that is another big challenge. And then a lot of these factors link in together. I'll talk about some of the behavioural risks we can alter, and that has an impact on things like blood pressure, anxiety and depression, all of these leading into well-being and health. Okay, so in terms of risk factors, does everyone talk to people about smoking? Yeah, okay, so I mean, smoking's pretty convincingly not good for MS, isn't it? But things happen quite quickly when people change. When people stop smoking, there's very quick changes. Carbon monoxide going down in your blood by 1 to 9 weeks, cough and shortness of breath becoming less. A year after quitting, less coronary heart disease. And by 15 years after quitting, risk of heart disease is equivalent to a non-smoker. So it's really important that we intervene, because we're not just thinking about MS, we're thinking about people's overall health, aren't we, and living with MS. But from an MS perspective, there's really interesting data that smoking does seem to have an influence on MS risk. If people have quit 10 years before baseline, then their risk is normal. And there is some interaction probably with genetic factors. But the really other interesting thing in big studies is there is an increased rate of progression in smokers from EDSS 4 to 6. And the time to development of secondary progressive MS is reduced as well. So I think, you know, when I'm talking to people about smoking now, I'm talking to them about the effect it can have on their MS, you know, that we acknowledge the effect it has on lung cancer and heart disease, but it does have an effect on MS now, and there's accumulating evidence for that. One of the things they looked at in this really big study in Canada was what other illnesses people had when they were presenting with MS. So vascular disease is very common. So we're thinking about things that we can check or be aware of, like diabetes, blood pressure, to reduce the risk of vascular disease, depression and anxiety, bipolar, but also autoimmune thyroid and psoriasis. And one of the things is, we talk about comorbidities, so I think about someone with MS has a comorbidity of psoriasis, but the dermatologist will think they have a comorbidity of MS. So it's a bit of a funny term, but we're talking really about the whole burden of illness that somebody has. The vascular comorbidity, this is another of these really big studies. So this is a big North American register study, and they've got really nice studies of big groups of patients, and they looked at these vascular comorbidities. And again, this increased the risk of disability progression. So in terms of intervening, you know, there's good evidence of reducing progression. And actually, this is quite impressive from this study, need to walking assistance from 18.8 years to 12.8 years. So a really high risk for early gait disability with vascular comorbidity. And then the other interesting thing about the comorbidities is delaying time to diagnosis. And you can just imagine this, because when someone goes to their GP and they've got other conditions, then often the MS symptoms are put down to the other condition. In the same way that we often say people with MS go to their GP and everything's put down to their MS. You know, so in the reverse way, that diagnosis doesn't get made. And in this big population, the time to diagnosis, MS diagnosis overall was 4 years, but there was a big diagnostic delay for those people with comorbidities. So I think all of these are evidence of why it's important to think that we can intervene on some of these things which do cluster with socioeconomic status. And then depression and anxiety, we know that depression is very prevalent. Anxiety, I don't think we measure as often, but anxiety is very frequent in people with MS as well. And again, when we're talking about these complex decisions, if you're anxious and you're starting to mention PML, then how you then think about that risk is actually some people with anxiety can't even bear to mention PML. You know, it makes them so anxious. So again, we're thinking about that in the context of big treatment decisions. And when they looked at sort of psychiatric comorbidity and progression of MS, interestingly, people with psychiatric comorbidity tended to have a higher EDSS score, and they adjusted it for disease duration, age, sex, and also for disease-modifying treatment therapy. So all of these factors seem to be having an effect on MS, and perhaps explaining why MS is so much more varied than we would expect in terms of giving people the same treatments and actually what then happens to them. So, I mean, I'm sure a lot of you have seen this stuff about the brain health. And do you use this kind of guidance of healthy brain healthy lifestyle? Yeah, I mean, I think it's quite engaging, isn't it? So it's quite useful to show people with MS because it does highlight these, and it is around those important things about avoiding smoking, keeping your weight under control, all of those things which hopefully add on to better outcomes for people with MS. So, what about socioeconomic status overall then? So a lot of these comorbidities can cluster with socioeconomic status, but do we think that that has an effect overall on your progression of disability in MS? What do people think? Do you think because of your socioeconomic status you can have worse progression of MS? Yeah. Okay. So this is really nice work that was done by Catherine Harding, who went over to work with Helen Tremlett in Canada, and they looked at the British Columbia and the South East Wales MS databases, and they were looking at the impact of socioeconomic status on MS progression. And this table, just really shows you that the populations were pretty matched. There are just over 2,000 in British Columbia and 1,000 in South Wales, but pretty matched populations. Okay, and they found exactly what you might expect and what you will be seeing with the people that you're working with is that actually there's a lower risk of getting to EDSS-6 if you have a higher socioeconomic status at your MS diagnosis. And they managed to show this was equivalent. I mean, so these are two different populations, aren't they, in British Columbia in Canada and Southeast Wales, but the results were pretty significant, actually, and showed the same effect in both populations, that there was not only a lower risk to getting to EDSS-6, but a lower risk to secondary progressive MS. And this is what I would think about as our bigger picture. So lower socioeconomic status is associated with a 9 to 10% increased hazard of reaching EDSS-6, EDSS-4, and SPMS. That's pretty big, isn't it? I mean, that's pretty significant. I mean, to be controversial, I would say that higher socioeconomic status has a bigger impact on reducing disease progression than some of our current DMTs. You know, I mean, that is the bigger picture, isn't it? One of the things, I don't know, probably, was probably quite a small release film, The Selfish Giant. But if you want to see what austerity Britain is like, then Liz will know, this is in Shipley. This is the scrap metal place in Shipley. It's about 4 miles from where I live. And, it's a heartbreaking film. And I think it does make you think, actually, about our patients living in that sort of real significant deprivation. So we've talked a bit about health behaviours, and we've talked about the social and economic factors, and I'm just going to then briefly pick up employment, and I will pick up access to care. I'm just thinking that all of these things are adding together to the best outcomes for people with MS. So I've been doing quite a lot of research on employment and MS. We're seeing people at the early stages of their working lives, aren't we? Or even they're students, or they're just setting out on their career. So it's such a crucial time for people when they get the diagnosis of MS. And what we know is about up to 80% of people with MS leave work within 10 years. Well, our age of diagnosis is late 20s, early 30s, so we're actually ending up with unemployed people at a very early age, in their early 40s, unemployed then. How's that having an effect on the family income, on the family dynamic? So we developed a measure called a work instability measure, because one of the things that I found really hard in clinic was actually you're hearing when people have lost their job. So people are coming to clinic and tell you they've lost their job. It's really hard to get people back into work, isn't it, when they've already lost their job? And what I think we need to be working at is keeping people in work. So this is a scale, it's quite a straightforward scale to use, self-completed by the person with MS, which shows that it predicts whether they're at risk of job loss. And we did a big study of about 200 people with MS, looking at the variables for continued employment. And we looked at lots of psychological variables, including anxiety and depression. We looked at type of MS. We found that the work instability was predictive. So if you had a low baseline, it increased your odds of keeping your job. The big psychological factor was self-efficacy. And self-efficacy really increased your job retention. And I think one of the things we know is that people are so vulnerable at this stage, aren't they? They're so vulnerable, and employers don't know much about MS. And so it is so easy to almost be persuaded out of the workplace or to give up, actually. Age also had an impact. So being over 50 really increased the odds of losing your job. So we're just starting a new study which is trying to prevent job loss, and we're working with the University of Queensland in Australia. They've developed a really good course called Ready for MS. You might not have heard of it, but it's worth looking at it. They set it up as a group acceptance and commitment therapy, and now we're developing an online version, so we're going to be testing that in working people with MS. Collaborating Birkbeck, our Centre for Sustainable Working Lives. So this is around can we keep people in employment? And this is about people who want to stay in employment. This is, this is about people who want to work. It's not about forcing people to work who can't work. So it's about supporting people to stay in employment. So I think there's lots we can do. The first thing is, I don't know, I've been doing some work with Shift MS. They got some funding from Comic Relief about work and MS. I mean, the first thing we can all do is just ask about employment when we're talking to people with MS and be a bit proactive, actually, about, are you having problems at work? What can we do to help? Some of the things are so straightforward. I've got primary school teachers who, just because their headmaster moved where their classroom was and they were, didn't have to take the stairs nearer the toilet. I think the employers get scared that we're going to be suggesting really huge changes. But as you know, pacing for fatigue and things like that at work can have such an impact. Okay, and then you'll have seen the unplanned hospital admissions slides from the MS Trust. Main cause of unplanned admission, urinary tract infections. I'm sure a lot of you will be familiar with the work that Bernie did with, trying to prevent admissions for urinary tract infections. And, the costs of that. And this is just going back to the access to healthcare in our different populations. And this is interesting. This is a slide that Gavin gave me, but this is looking at the areas of Hackney and Tower Hamlets. I don't know if any of you are here from that service, but this was comparing, and I think they were trying to build the case for Newham for a new MS nurse. So the unplanned hospital admissions in these areas were 13.9, and in Newham with no MS nurse, 24.4. Now, I know, there may be other factors. I don't know these populations, but actually, we would think that when urinary tract infections are the prominent cause, that actually having a good MS nurse on your side, helping to sort stuff out for you proactively, would result in less unplanned hospital admissions. And I think there is that geographic variability as well. And it may be that if you may know, somebody may have done it, but if we map MS nurses to areas of socioeconomic deprivation, how does it map? It might be interesting for us to look at that. So just to sort of tie things up together, as part of the Multiple Sclerosis Academy, we've started a new work stream at the last meeting on social determinants of health. So to look at these issues like employment, like family income, communities, social support. Social isolation is such an important factor. And what we're going to do is, this year, is an audit of UK MS centres. First of all, to see, do people have a register of their patients and roughly what the population is? And then, do they have any markers of socioeconomic status? And the easiest marker is the postcode. So you can start to see, is there a gap? Do you think that you're seeing patients, or are there a lot of patients lost to your service? Why is that? And then whether, when you're seeing people, are you talking about any of these? I know a lot of you will, I think at the moment, feel quite overwhelmed with the amount of work that you have. But as Karen says, fundamentally, this is part of our job, isn't it, really? And then the other thing is about social prescribing. This is about people with social isolation, and does social prescribing help them? And there are some novel schemes across the country that you might know about. So I haven't done badly with time. I've caught up. So what I would say is, I think social and economic factors may explain some of the variation we see in MS outcomes. And I think I've shown you that there is an impact on survival, on quality of life, and on disease progression. And I feel quite strongly that poverty does result in MS health inequalities. And I think I was just going to end as a call to action for all of us, really, that as MS healthcare professionals, we need to think about these social and economic factors. In the community that you work in, because you're the people that know the community most of all, and how they influence the management of MS in lots of different ways. It would be great if people can participate in that audit when it comes round. I think it's really crucial that we support people with MS in maintaining employment, and then we're proactive about it, and that in the work that Shift MS did, one of the things was, whose job is it to, in our teams, whose job is it to ask about work? And in summary, it is all of our jobs. So it isn't something that is one person's job. And there is really nice stuff around. I don't know if you have seen the sort of making every contact count. And I think we make every contact count by not just thinking about MS specific issues, but thinking about some of these wider issues too. We won't be able to do it, all of these at every contact, but it may be that at one contact you do flag up employment, you do talk to them about how their job's going, and you have that conversation. And then I think all of us, I mean, especially you will have dealt with it so much more than me, but in the things like PIP and the effect that that is having on people's lives with MS, I think we all need to be really vocal advocates for people with MS. Okay. Thank you.